Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are...
Okay.
Hello.
I started us prematurely.
It's like, wow.
That happened before we were ready for it.
I wasn't ready.
I guess I should take an SSRI because
Something's premature.
some people would get that joke. We are starting our show today on treatment for cancer.
Ooh, exciting.
This is kind of a broad overview, which will include the latest, but we want to back up a little bit and talk about how we got here,
Sure.
where we've come from, and we want to communicate with our audience and greet our guests who are talking to us, like Robert Antonio, who is greeting us and saying hello. Good day, doctors.
Good day
to you too, Robert Antonio. We're glad to have you be on the show.
Yeah.
So anybody else who wants to write in, you just use the chat function if you're watching us live here at 4:30 on a Monday afternoon, and you can be a part of the show and comment and ask questions and do super chats if you want, because that's how we pay for our Dutch brothers.
Yeah.
Thank you.
Caffeinated up and ready to go.
I think I started before the show. Anyway,
Get it all.
so thank you. Cancer treatment. So this comes
Cancer
from
treatments.
Dr. Gwaine came up with this show for today because he came across the cancer vaccine.
Ooh, that is.
Yeah.
Doesn't that
one?
sound
Ooh,
enticing?
Cancer vaccine. Okay.
Clickbaity.
And it worked because it got us to look at it. So that's
got me to click.
yeah. But we should back up about what cancer treatment has been before the cancer vaccine.
Sure. Yeah.
And we will comment on that and how much of a real thing or not, or
Yeah.
what evidence there is so far.
Sure.
Yeah.
And maybe if anybody is listening or watching or who has gone through some of these treatments, maybe you can comment on that and your experiences.
So in the old days, so we're talking, how far back would you have to go before the first chemotherapy? I actually don't know, but what was
Some of the
done?
early ones were probably pretty harsh.
What was done was
Trying a lot of
operative
things.
treatment, surgical.
Yeah. If it could
Big
happen.
tumor, remove it.
Mhm.
And probably, I don't even know what the studies show. I would guess that the success rate was not that great with treatment compared to not treatment.
Sure. Yeah. Because that was in the early days of
Yeah.
surgery, anyways. So you had all the risks
Yeah.
associated
So if
with
you go back
that
to
and
like the 50s.
putting people under during those times with
That too.
fairly primitive equipment.
So the like breast cancer, radical mastectomies.
Just take it all.
Take the muscle, take them down to the
To the chest wall.
all the way down to the bones there.
Yeah.
These people were disfigured. The amount of tissue that they would remove, going all the way, all the skin, the breast, completely remove the breast, the skin around it, the muscle under it, in an effort to get ahead of the cancer
Spreading and
because back then they didn't have mammography to detect.
to catch it really early. Yeah. If you found it, it was because you did an exam and if you feel it, it's big enough that it may have already moved, metastasized.
Most often it's the patient who discovers.
Come in, felt the
There's
mass.
something weird here. Doctor, what is this?
Yeah.
So, thankfully, we're in a completely different age of treatment now. So,
Right. Yeah.
That was
catch things
surgical only.
really, really early.
And then after the surgical only time, there'd be the surgical, and I don't know what came first. Was it radiation therapy or was
it the radiation chicken or the chemo egg?
Yeah, which one was it?
That's a good question.
So we'll talk about both of them.
Yeah.
So radiation therapy, which is still used today, to start out with, it was broad beam of radiation coming from
lots of exposure.
one place to the body area affected, and of course, because it's all going through the same place on the skin we'll use breast cancer to continue because we were already talking about it's going through the skin from wherever the source of radiation is. The skin is getting the worst of it, so you're getting these burns in the skin.
Right.
It's probably also hitting the GI tract and causing injury there, which can kill off the rapidly dividing lining cells of the esophagus, so you're going to have injury to the esophagus.
Pretty much anything in that blast radius, as it were, anything there.
So you get like strictures,
and even the lungs, some of those lungs, it'll kill some of those cells that help beat out mucus and stuff. So lots of collateral damage, unfortunately.
And
that has improved drastically.
So now instead of just having it come from a single external spot,
multifocal, all around you, and kind of even in all dimensions, where the focus or where all those hit is right where that mass is.
Yes.
It's pretty amazing. And they have all of these algorithms and logistics they go through with, like you probably see it here in some of your patients, where if it's somewhere they got to sit at this certain place and they actually like strap them there so they don't move at all, so they can get it right focused in on where that mass and that growth is, and which can really be even small growths. So pretty neat technology.
Yes, and amazingly focused, so that any other tissue of the body is getting
minimal.
Tiny,
exactly.
Tiny dose compared to
that one area.
And then chemotherapy would be the next.
Right.
So the purpose of
which some of the early ones were intense. So yeah, essentially these were the early ones disrupted cell division, which happened at the cellular level with DNA markers and things like that. They would go in and actually disrupt the DNA and some of those different pathways that lead to mitosis or cell division.
So you're talking about when cells divide. That's how they multiply. That's how it grows.
Exactly.
So essentially, we're hitting any body tissue
that divides and grows.
That is always being turned over, like the lining of the GI tract.
Common side effect: nausea, vomiting,
tract.
diarrhea. Lots of side effects.
The immune system, the blood.
Yeah, which is often rapidly dividing. And early chemo was just wrought with side effects. You would be sick. And I remember some of the early oncology doctors that were my professors saying, hey, early chemo, essentially what we were doing is killing you, just hoping that we would kill the cancer first and then bring you back. So it was intense stuff.
The old days.
That's gotten better, and we still use chemotherapy, and for some cancers that is the primary treatment, but it is a lot more focused on the certain ways the cells divide or the certain types of cells that they are. So they're a little better, and you don't have
a little more targeted. They have more than one option.
Exactly. Yeah.
And now that brings us to immunotherapy.
Yeah, which is
next step.
Which is current standard of care for many cancers. It's kind of started off with the non-small cell lung cancers. That's kind of seems to be where most cancers kind of start, or not cancers, most cancer treatments start out, because that's such a common cancer, which actually now has decreased greatly because of these new treatments. And the treatment is different. So it's not essentially a toxin going into your blood messing with that division pathway. We're actually using an immune, an antibody targeted against the cancer cells. So,
which then turns on your own
immune system
white blood
to
cells
attack it, essentially,
to do the job.
Yeah. It just basically, if you want to think of it, it finds that cancer cell, puts a tag on it that says, "Hey, I'm a cancer," and then your body says, "Oh, I got to attack that and get rid of it."
Yeah, it's responding to this antibody the same way it would, or antigen, excuse me, the same way that it would, like a bacteria.
Yeah,
or
exactly.
a virus. This is how we treat COVID-19. There's
similar.
We try to replicate the antigen and then get the body to see it and to identify that and make its own cells that will go after that particular antigen, have antibodies to go after it.
Yeah, and much fewer side effects. The biggest one is related to the immune system. You are at a higher risk of some infections and things like that. You need to make sure you don't have TB and certain chronic diseases that can unfortunately be turned on or start to have symptoms with. But yeah, it's a lot better than it was. I have many, and you probably have a similar experience, where patients come in after getting their chemo, and I remember 10 years they'd come in and they would look like death. It was bad. But now people come in, you wouldn't know, and they're like, I feel a little fatigued.
Yeah,
it's amazing.
It's a different. Yeah, so we actually have to counsel patients that what you saw your aunt or your mother or your grandma go through is not the treatment that they have now. it's worth talking to the oncologist about the options. Now, we've been talking about solid tumors.
Yeah, exactly.
We haven't been talking about blood. There's also advancements that have occurred there with bone marrow transplants, for example.
Right. Sure. Yeah.
So a person has their bone marrow, which is the inside of your long bones mostly, but other places too, that's making blood cells. And if it's making cancer cells, they can use that. Usually, I think it's the radiation is how they do it, if I'm not mistaken.
They can do that.
To kill off just essentially all the bone marrow in a person's body.
Take it out.
And then get a bone marrow transplant from a person who is a match. This doesn't mean same blood type. It's much more specific than that, and has to be determined by specific testing by whoever's doing the transplant. So you have these registries across the country, and you can look them up on Google, bone marrow registry or transplant donation registry if you want to register with those, which we encourage you to do. And then they will take the blood from the donor. I believe they get it from their bone marrow, actually.
Yeah.
But they don't have to put it back in the bone marrow directly. They just put it in the bloodstream and it finds its way there.
Yeah.
It's great. And start setting up shop. And after a while of being in isolation because they have no immune system, they start producing their own immune components in the blood. And they're able to leave the hospital and have a normal life from there on. They don't have to be on.
Pretty amazing.
Do they have to be on?
Some of those anti-rejection drugs.
Actually, I don't know that. I don't believe so.
I'm thinking of my patients, and I don't think they are on any of those.
Like you are with
like a renal transplant or
solid organ transplants.
Yeah.
So that brings us to what's in the news today, Dr. Levine.
Yeah. So that is the headline there. A cancer vaccine. Are we able to now? And you hear vaccine, and my first thought was, okay, do we have something we can give people to prevent cancers from even developing? Because that's what we think of as a vaccine, right? This is a preventive thing, and no, that's deceiving. Not what it is. So it is deceiving in that sense.
Yeah, let's correct that.
But it is vaccine in the sense that it works similarly to how we have vaccines work. So it's finding, and this is the mRNA technology. So this is similar to the COVID vaccine and how that works. Yeah. We have gotten so good at putting together mRNA sequences. We can sequence something and then make an mRNA vaccine against that. So the idea is that you find an antigen or something on those cancer cells once you've isolated those in a person. And this is individualized treatment, which is kind of neat. But you isolate those, go through the sequence of whatever that antigen is, and then make an mRNA vaccine against that, and kind of do the same thing that those non-specific immunotherapy did, but very specifically targeted at the cells, the cancer cells. And with this, you're going to have very specific therapy, which is not going to have as many side effects, fortunately. And it seems to be going that way. But it is very early, still very early. This is not coming out tomorrow, but we are entering some trials for it. So
the one that's about to go into stage 3, looks like it will, is specifically for prostate cancer. Stage 2 has shown some improvement. It's not 100%.
Yeah.
So, and the numbers, at least on the ABC News website, were a little goofy to me.
It was, yeah. We'd have to look into that a little more and actually look at the studies. Yeah. This was just a report. So
it was showing a survival over the period of the study of 60% for people who are in stage 3 cancer.
Right.
And 68% more for people in stage 4 prostate
maybe
cancer?
It's because they had fewer people in that stage. The comparative studies were kind of interesting too, because in the stage 3,
anyway.
Or stage 4, nobody made it. Like if you were a placebo receiver, everybody died, unfortunately.
Yeah, that's true.
So it is a actual
There's
chance.
A there.
There is a chance if you get this new vaccine versus not. So vaccine.
So we need to clarify, even though the results aren't. Boy, somebody's going on. I think it's Robert. No, Lindsay Antoine and Robert Antonio are both writing books over here. We'll get you on in a moment. Without the vaccine, you die from stage 4 prostate cancer. But with the vaccine, there's a chance, and it's about a 2 out of 3 chance.
Which is that is amazing for
on their
stage 4
studies.
Prostate cancer. That is amazing.
We'll
now
see
these are 3 years out or something like that. They're still but prostate cancer specifically, we have not had a good treatment for stage 4 prostate cancer.
Yeah, and I always want to get this information out. We don't have a good screening for it.
We do not.
The PSA test is not.
Yeah.
should not be called screening. Should not be called a screening test. It has been.
It is
but
a
it should
monitoring
not be
test.
Considered. Yeah, it just doesn't work.
Yeah.
Okay. So we have Lindsay Antwine, who is saying, my aunt was treated back between 2004 2005
Wow.
lung cancer that spread everywhere. It was like watching a horror movie. Absolutely terrible what she went through and died anyway.
Yeah, and I don't know if you're commenting on what she went through at the hands of some early chemotherapy there,
Right.
or at the hands of the cancer, because
Yeah.
both
2004,
at that
2005.
point could have been horrible. Yeah, because that cancer, like I said, you looked like you were death warmed over with some of those treatments. They were tense.
Literally.
Yeah.
And then we also have Robert Antonio saying, how will the mRNA vaccine work, particularly if the cancer cells mutate and the DNA sequence? Ooh. He found a
Yeah, so it
something
is
in their chain.
exactly. Yeah. So we're still able to. It's pretty rare that when we do a biopsy of a cancer that has spread somewhere, which sometimes we have to try to figure out where it came from. We still, when we do that biopsy and the pathologists look at it under the microscope, they're able to tell where it came from. Most of the time, it's actually extremely rare that they cannot, because they retain some of the characteristics of the primary organ where they came from. Now, how do you differentiate that from the actual organ? That's a little beyond what I'm able to tell you right now, but it will be something that is distinct to that organ type. And right now they're doing melanoma, that's prostate, but also melanoma. And I think they were also doing the
Pancreatic too, one of them.
non-small cell lung cancer as well. So it does sustain or not sustain, retain some of those factors of that. And there's something that would be different now. But you bring up a good point that it is a mutation within. But typically cancers mutate and then just keep going. It's the mutation is within the division mechanism, not so much within the cell structure mechanism. So it is a little different what you're talking about there. But yeah, great point. Thanks for bringing that up.
And we were even talking when we first started talking about this about, well, what if the antigen that they choose to use for the cancer cell, they don't know that exists in some other cells in the body.
Some other cells.
It's never been.
Yeah, I'm sure that they have. They're working with pathologists and hematologists, immunologists, all of those to make sure that this is not something that you're going to start attacking that normal cell that has that same antigen. So, but there is, that is what we were thinking as well.
But something to look out for. Mm-hmm. So thank you. Great comments from Lindsay Antwine and Robert Antonio on this subject of the new cancer vaccine. Again, these things, oftentimes they look a lot more promising when the company that's doing the studies is the one that's evaluating the data and letting it out to the public at the end of a phase 2 trial, which it looks like it looks like that's what's going on here. Mm-hmm. And sometimes it turns out, or the other side of it is, how much does it cost to get the current immunotherapy, the current state of the art, before this comes out? How much does it cost? And
this is going to be even more individualized. I mean, can you imagine? We know that the current immunotherapy, we've seen some of the numbers, tens of thousands, beyond hundreds of thousands.
$100,000 to $250,000 is what an oncologist told us to our face.
Yeah, that's right.
Some of the treatments
some of the newest
cost.
ones,
And they happen. Somebody's paying for it. An insurance company.
An insurance company is making that payment.
That's where your healthcare dollars are going in this country that has worse healthcare than some of those socialist countries in Europe that spend less money. Just throwing that out there.
Wow. This took a political turn quickly. Anyways.
I guess you could call it that. I was just pointing out what. I guess I thought it was an economic comment. I didn't realize it was so political, but yeah. Okay. So any
We're
more
in
comments
America.
from? Oh yes.
Everything's political.
We have Lindsay Antwine, both on. Oh, she was talking about her aunt with the treatment and the cancer, what was affecting her body. Okay. Hey, we made it through a show without it shutting down.
Yeah.
We started prematurely.
Maybe you were just excited.
I'm so excited.
Wanted to get it going this week.
I couldn't keep waiting.
Oh man. Anyways,
we hope our audience was able to get to the
enjoy
point
it
that they
right
enjoyed the show
along with us.
Yeah.
Yeah.
So thank you again Lindsay Antoine, Robert Antonio. Robert Antonio. I'm not a fan of the NHS. Yeah, we weren't talking about the NHS. We were talking about Sweden. But anyway.
Sweden.
How can I turn? There we go. So we will be back. Will we be back? I think we will. I think we'll have a show next week.
Okay. I don't think I have any plans.
Not the week after that, but yeah, next week. So
cool.
If anybody out there, I don't expect it to be, but if anybody out there is attending NAM, National Association of Music Merchants this week in Anaheim, look for me there. Until next time,
I'm Dr. Wayne Vaughn.
Dr. Mark Vaughn telling you to have a good week and stay in good health.